Awesome. Okay, so on to why we're all here tonight. So back in 2021, Foxglove, Just Treatment and other partners joined forces to challenge the government's dodgy plans to share NHS patient data with private companies without our proper consent. After 2 months of non-stop pressure, our collective campaign saw millions follow the guidance of our allies Med Confidential, to opt out of the planned scheme, ultimately forcing the government to back down and delay their plans indefinitely. Our message then was clear that this is our health data and what happens to it must be our choice. Fast forward to now, and the government is back with the latest iteration of its secretive plans. They intend to create a huge federated data platform for our health data in the NHS, but they've told the public almost nothing about it. Despite multiple attempts to get clarity by Foxglove, Just Treatment, and our other partners, the Doctors Association and the National Pensioners Convention, there are still major questions left unanswered. What is the FDP for and how will it work? How can we be sure our data will remain safe? And crucially, why is dodgy US spy tech corporation Palantir being lined up for the £480 million contract? So tonight we are joined by Foxglove Director Corey Crider, NHS GP Dr. Marcus Ball, NHS patient Izzy Jolly Friend, and Just Treatment Director Diarmuid MacDonald to discuss what we know about the Federated Data Platform so far, why we should be worried, and how you can all get involved in the campaign to challenge it. After we've heard from each of our speakers, we're going to have time for a question and answer session, and then we'll conclude the call by running through campaign plans and actions. So without further ado, I'm now going to hand over to Corey, who is going to give us the lowdown on everything we know so far about the Federated Data Platform. So over to you, Corey.
Hello, everyone. I'm so pleased that so many of you have decided to spend your Thursday evening talking to us about health data. But I think that shows just how important this is to a lot of people, because let's be honest, our medical record, it contains some of the most sensitive and personal information that we may have in our lives. And we sometimes tell doctors are things that we may not be comfortable telling even our loved ones. And the moment that Marcus will talk more about this, I'm sure, but the moment that relationship of trust starts to fray or break down, then I think we've got a real problem at the heart of the NHS. I just want to say a little bit about who I am and who Foxglove are, for those of you who haven't met us before. And then I'll talk a little bit about why big tech in general is interested in the NHS, not just Palantir, to be honest, but a whole host of tech companies. What we know about the Federated Data Platform, which sometimes feels like it could be fit on the back of a beer mat, but I will tell you what we have been able to find out, and what we don't know, which is a much longer list of things, and what questions and concerns that we have about it. So I'm Corey. I'm one of the founders and directors of Foxglove. We set up in 2019 with Martha and Rosa, my two co-founders, and we are a tech justice nonprofit. We seek to make the use of technology fair for everybody and to sue when it isn't fair. And we have been involved since 2020 with partners like Just Treatment, Open Democracy, the National Pensioners Convention, David Davis, a host of groups, in a series of legal challenges to the government's plans for our health data. And the basic principle that we are seeking to defend in these legal cases is not we can't use health data for any purpose at all. I think a lot of the people on this call, I noticed there seemed to be some nurses and others, would probably agree with me, I'm the child of two scientists, that we actually want to see the NHS use health data well, provided that there is trust and consent and governance for the public good and the good of the NHS. The NHS is in a crisis now, and I think we all think that anything that will help it survive and help it meet its needs for the future can only be a positive thing. But you can agree with that principle and not think it's a great idea to get this system in and centralize control and power over that data, particularly because you may be worried about what people in central government want to do with it and the extent to which they want to open up certain kinds of private access that you and I might not agree to. Anyway, so Foxglove, we help groups and we stand with groups to bring legal cases when there are concerns, not just about health. I'm not a health charity. If you remember A-level students having a problem with an algorithm assigning their grades a couple of years ago, we were involved in the legal action around that. So we do other cases as well. But if you have an issue to do with data, bring us up. We may be able to help you with a legal action, basically. So what has this all, what's Palantir about, and what's big tech in general potentially got to do with the NHS, and why are they interested in it? The most important thing to understand, I think, is that NHS data is special. It's in some ways, it's one of the most special potential data sets in the world, because the NHS has been what Americans call a single payer system, a national healthcare service, free at the point of delivery nationally for so long. And in particular, GPs like Marcus have for many, many years, decades, I think, been participating in a system where they code everybody's record. When you go down and you tell the GP, I have a heart pain or potential skin cancer or a bunion or whatever it is, the GP will encode that in a particular way into your record. Those codes can be read by a machine because they are consistent. They're an alphanumeric code. And so what that means is that taken together, the records of everybody in the health service who uses the health service and has for years is probably the biggest set of machine readable, population-wide health data, possibly on the planet. So it's a very, very large asset, particularly when you're talking about certain kinds of assets like the GP data codes. That is an asset of immense interest, not just to planners or people in central government or your doctors or your hospitals, all of whom want to use it for good and for your care and for planning potentially, but it's also of interest to a host of potential private corporations. Basically, you can imagine, we've all seen a lot of the news around the kind of developments in artificial intelligence and machine learning of the past few years. I just read an article this past week about Microsoft partnering with Epic, one of the big providers of electronic patient record systems here, about unleashing ChatGPT on Americans' health records. I mean, thank your lucky stars, you've still got GDPR here, so that can't yet happen in America, in the UK. But anyway, there are people there are companies and corporate interests who definitely are interested in accessing population-wide data sets because they believe that will permit them to develop products and services. Now, some of you might be interested in that. You might think, well, hey, I want to help a pharmaceutical company, potentially develop something. But I think that the idea behind some of the legal actions that we have taken with Just Treatment and other people's involvement is that should be up to you. If somebody wants to opt into a clinical study, then that's a matter for them. If other people don't want to do it, then that should also be up to them. And where you start to lose trust, I think, is where there's a risk that you take information from people without their trust, without public consent. So what's this got to do with the so-called Federated Data Platform, and what do we know about it so far? This goes back to what fits on the back of a beer map. All right, so despite what I've just said about the potential power of a lot of NHS data systems, that power at the moment is distributed and it's pretty diffuse because health data is held in a whole bunch of different systems that at the moment don't talk super well to one another. So, for example, you might have a surprising experience. I've had one of these myself, where you go to the hospital for a particular kind of care. The hospital may not have all of your health record actually accessible. And if they want to then get a decision made or a piece of care that you've had at your hospital back to your GP, there may not actually be a ready-made situation in place where it's easy for the hospital to send it back. To tell you a situation I had myself, I went in for a particular skincare treatment to the hospital, and the guy at the hospital, this really happened to me, said, I can produce you a letter and I can go through our internal system and send it to your GP, but that system is going to take me 5-6 weeks. Or you can wait for 10 hours in the hospital pharmacy where I'm allowed to dispense your prescription, or you can be your own cycle courier and you can take what I have to say from the hospital back to your GP. So that's what I did. But, thank God I could do that. I could ride the bike. But clearly there is a case to be made for joining up data better for people's direct care and for planning. In theory, that is what the government is saying the Federated Data Platform is for. It is an effort to take a whole bunch of different data sets. So that is data sets held by GPs, data sets held in hospitals, potentially in time social care data, and make it accessible, all of it for everybody nationally for the first time into a central platform that can be read by planners in central government. That's not the same thing as sucking it all, into one server. But in a way, if central government can read it all, I'm not sure that that matters. The point is that they can, it's going to pool it all. It will be, if it goes through as designed, the largest single point of access to patient data that the nation has ever seen. And the front runner to manage this contract and to provide the interface through which to do the data integration, to do the data cleansing, to help with some of the analysis, to provide the consultants who will have to be in the NHS from now until kingdom come to provide it, is a company called Palantir. I'm assuming that quite a lot of the people who have dialed into this call have heard of Palantir, but I just wonder, nod, Hope, if you think if it's worth my saying who Palantir are, just for like 2 minutes, maybe. Yeah, dear. Okay, there's some nods. Palantir are not a company who had a track record in healthcare. They are a tech company. Their headquarters is in California. They are an American company. The chair of their board is one Peter Thiel, who is he's one of the PayPal mafia tech billionaires, a pretty right-wing person, major backer to Donald Trump and other far-right Republican candidates in the United States, who once famously wrote in an essay for the Cato Institute a few years ago that the extension of suffrage to women like myself was a mistake. So not one of life's bleeding heart liberals. Anyway, the chair of the board, and thought to be, although it's not public, its largest shareholder. Anyway, it's a company whose background was not in, I agree with what somebody just said. There's a comment that suggests it's like care.data. We'll talk more about the predecessors maybe later. But anyway, it didn't have a track record in health, but it was interested in, what it did have a track record in, I suppose, was government contracting. It was originally funded by the CIA's venture capital arm, In-Q-Tel, and its original government contracts were supporting mass surveillance by the NSA or GCHQ. We know this from some of the Edward Snowden documents, predictive policing in the United States, and indeed actually in Germany. Germany's constitutional court recently found that a German authorities' use of Palantir software for potential predictive policing purposes was in fact unconstitutional, and border enforcement. So they were directly involved in things like family separations under the Trump administration. So pretty pointy uses of state power, if you see what I mean, special forces in Afghanistan and Iraq. I mean, you kind of name it. If there's a controversial government activity, Palantir may have had a data management contract assisting the government to carry that stuff out. However, there's only so much money in that kind of government contracting, and health is another pie, a big pie that involves tax dollars. And so they, in particular in the United Kingdom, particularly with the NHS, have had their eyes on the management of health data for a while. They started lobbying and wooing NHS executives, including the then chair, Lord Pryor of NHS England, over quite cozy dinners. We know from FOI, watermelon cocktails, these sorts of things. I'm sure they were delicious, but perhaps not the basis for assigning major government contracts. Anyway, as long ago as 2019. The then chair of NHS England flew to California to be shown the software and how it could be used to kind of pioneer the next generation of patient treatments, et cetera. And then, of course, the pandemic struck. And suddenly all of the usual restrictions around government contracting and around protections for patient data were put on hold. And so Palantir came in. That was their signal to pounce, and they did. They won for the first time ever by offering to do the work at first for £1, a contract to manage something called the COVID data store, which was a big pool of everybody's patient data, only legally possible, again, because of the pandemic, that was supposed to help the government respond to the crisis. They said they didn't need people's consent, and they definitely didn't need to go out to a competitive tender, basically because of the emergency. The price of that contract went up from £1 to £1 million to £23 million, and then they had another 17 million extension. But all of that was only ever the test run for the big prize. And the big prize is now the permanent system that the government is procuring, the Federated Data Platform, whose price tag is £480 million. Now, some of you are nurses, some of you are, I don't know if any of you are, well, Marcus is obviously a doctor, and we all know that the NHS is facing its greatest crisis, perhaps since the service was founded. And we do think it's a little bit troubling that it can be simultaneously the case that the government isn't willing to give junior doctors more than 14 quid an hour, and yet thinks that it has the money sloshing around to spend £480 million on the first of 4 procurements, by the way, for this Federated Data Platform. Anyway, Palantir say that they're there to provide the pipes. They're saying, look, we're not a data broker. We're not actually like big pharma. We're not going to sell your data onto somebody else. And I have no basis for telling you, by the way, that that's not currently the case. But the issue with the Federated Data Platform is this: without governance, without oversight, and without you having a say, all of a sudden, a massive contract is going to a corporation who has historic issues that we think will undermine patient trust, that will lock in a single private monopoly into the management of the country's health data, potentially for a very long time, and where the government hasn't been clear, even in quite a lot of tender documents, about what uses it wants to make with this data. There are 4 initial use cases stated in the tender documents, but they explicitly say, for example, that they want to do further procurement. One of the things that there's going to be a further procurement for is for a marketplace where people can come in and develop apps, supposedly out of certain kinds of access to health data. And yet at the same time, they say we don't have to seek people's consent for this revolution. They simultaneously say this is a revolutionary system. It's going to totally upend and overhaul the way that we manage the data of patients in this country. And simultaneously, that we don't have to go out and consult people, and that we don't need people's consent because we have separate legal bases to do this, and because the data is pseudonymous. They don't go so far as to say it's anonymous. What they've done is essentially slap a sticker over your NHS number, but they say that that excuses them from all the legal protections for patient data. I'm conscious of time, and so I want to give people a bit of time to ask questions and respond. But I would say that the kind of core concerns with Palantir and with the FDP are this, and then I'll hand it over. One, we think it's more centralizing than it needs to be. There are a lot of good local experiments with pooling health data in a more trustworthy and safe way, for example, in Greater London, or with the Oxford system Open Safely, that is totally open source, totally safe, totally different from Palantir. So there are better alternatives that are being ignored by this. 2, it's bloody expensive at a time when the NHS is at a huge crisis and is gonna get more expensive. The price of these services never goes down. And 3, it appears to us to be, if it is this transformational change, it's riding roughshod over questions of democratic consent, patient trust, and patient choice. So anyway, there are a lot of concerns with it. I could go on, probably ad infinitum, but I want to give other people a chance to speak. Thank you.
Amazing. Thank you so much, Corey, for that fantastic overview, and also for all of the amazing work that you and the Foxglove team have done on this issue. I'm sure there will be, well, there definitely have already been some questions for you, and I'm sure there will be more, which we're going to come to in a bit. So just a reminder to everyone, if you have questions, put them in the chat and we'll collate them later for the Q&A. We'll try and get to as many as we can. But next up, I'm going to hand over to our next speaker, NHS GP Marcus, who's going to give a doctor's perspective on the dangers of the FDP. Over to you, Marcus.
Hello there, and hi from York. So I'm a GP working in the NHS. I've become a bit of a sort of, well, I've been heavily involved in GP IT for over a decade, and so it's become a bit of a specialism of mine. But I think I would echo all the concerns as a clinician that Corey just outlined, because they are absolutely our concerns as well. But I would then go on and add to them about some of the things that we're most concerned about. And I think the absolute top line concern that we have is that because this program is an utter confusion of different types of data for different types of uses, and the patients have not been consented for the uses of their data like this, the worst case scenario, which I think is actually quite plausible here, is that patients will stop telling their doctors important piece of information because they'll be concerned that it will end up in some kind of national database. And I think that patients are actually very right to have that concern, because we as the profession have not had the safeguards outlined that tell us why it's safe to put this data in Palantir, why it's safe to have a national database. Because actually, there are data programs going on right now across the NHS, and we do handle a lot of data, as mentioned by Corey, in coded form for the patient's benefit. And that's the absolute key to it. We only do that because it enables us to give better care. So when we code a piece of information, so if we put in say, for example, one of the asthma codes into your record, that helps us to recall you for an asthma review. So many of you may have asthma, and you'll get an invitation for an annual asthma review. And the system that powers that is totally private. It's run on the GP's own system, as it were, just within the patients that belong to that GP. And it enables them to send out an invitation to you by text or by letter saying, would you like to have an asthma review? So there are completely legitimate reasons why we would use a combination of plain text and coded data to manage somebody's care. But what we are very concerned about as a profession is when that data gets sucked out by an enormous pipeline and sent to what is essentially the government. So NHS England is a branch of the government. It's a wholly owned subsidiary of the Department of Health and Social Care. So that's too much power for a government to have. If they have detailed data about every citizen's healthcare, it's a certainty that that data will be abused at some point, because that's what any power does. It allows people to abuse the level of power that they've been given. So if we are to participate in a program like this, then patients need to be informed as to what is proposed and how it will safeguard their data from abuse. And we as the profession, we also want those same safeguards. We want to know how this data, when it moves into NHS England, will be protected from abuse. Because it's very easy to imagine in the world we live in and the experience we went through the Vote Leave campaign, which was tainted with dirty data, as it were, using many of the same companies, including some of the same figures were involved that are involved in Palantir now. And we've had a pandemic where data was the data rules were suspended for convenience of the government, essentially. We don't have any guarantees that they wouldn't start using sneaky queries on your healthcare data to enforce border controls, which would be a complete abuse of the healthcare system. And of course, that kind of scenario, whilst it might seem very sort of dystopian, with the current government we have, it isn't that difficult to imagine it could happen. And of course, as a professional, I don't design my security around even the current government, because once data is in the hands of the government, you can't get it back. So we have to design our security and our privacy practices around the worst imaginable government, not even the government we have, but what is the worst imaginable government and what would they do with it? And then you have to protect your data accordingly. So that's just about thinking about the problem and planning how to protect this. So we have grave concerns about the program. We have grave concerns about the lack of professional engagement that the government has gone through to agree what will be done in this program, and we also don't think the public have been consulted. There's very little information out there about what is going on. It is not exactly the same as the care.data program, but it's a very similar level of lack of consultation. So it's got lots of similarities with care data. And actually, after care data happened, we as the profession who were involved in GPIT, we worked together with the government for over 4 years to try and develop the next generation of data platforms across the NHS that would have had the backing of the profession. And that was called GP Data for Planning and Research. And that program has now been paused. So the actual professionally approved version of this Federated Data Platform has been paused because NHS England wished to pursue the FDP to its maximum. So in terms of what the FDP actually proposes to do, we know almost nothing. What we've been told is a dangerous mishmash of different users of data. And we've talked about data already a little bit, but one of the problems that genuinely does exist in the NHS is that when you go to one care-giving organisation and then travel to another one, as Corey gave the example of, the data often doesn't follow you properly. Now, there is nothing in the Federated Data Platform that will fix that whatsoever. It's not for that. So your direct care experience of data across the NHS will not improve because of the FDP, because it's not for that. What it's really for is dashboarding and planning and possibly even arranging some research projects at national level. And that's not of any interest to individual patients, really. The only people who particularly get excited about that are NHS England themselves, because it allows them to dashboard what's happening across the NHS. But it doesn't put you in any better stead as a patient receiving care, because you will still have exactly the same problems of lack of joined up care across different areas of the NHS. So that absolutely needs to be addressed and blown out of the water, that if NHS England are suggesting that your journey as a patient will be improved by this, it will not. There are many, many other inconsistencies about the types of uses NHS England think that they will be able to use this data for, but haven't yet sorted out the legal basis on which they will do that. And that is a very complicated area. There are at least 4 or 5 different types of use of data, and for each of them there is a different sort of legal basis on which you can legally use the data. So I'm just really highlighting that there isn't even enough in the public domain for us to have specific concerns about what they plan to do. The only thing we can do as a profession is address the things that it won't provide for you. It will not give you certain improvements in your care that you think that the NHS England are happy to let you believe that it will improve. And that's the most dangerous bit about this. So I think I'll call it to a close there, but the key message is that I want you as patients and professionals that's involved in this to critically appraise what type of data is being used and for what it's being used. Because I think NHS England at the moment are profiting from the fact that if you say NHS data to one person, it means a different thing than it does to another person. And I think they're actually sort of riding on the coattails of the fact that many patients have had a disjointed data experience across the NHS, and they would like to see that improve. And so NHS England are sort of letting them be sort of misinformed into thinking that this Federated Data Platform will improve that, and that might get rid of some objections, when in fact it will not improve your data journey, and your overall experience of the NHS will not improve at all. So we've got to challenge that assertion and make them be very, very clear and honest about exactly what benefits can be expected. I'll hand it over back now. Happy to answer questions later.
Perfect. Thank you so much, Marcus. It's so great to have you with us tonight. And yeah, again, if you have any questions for Marcus or for Corey or for anyone, please put them in the chat and we're compiling them as we go. But before the Q&A section, next up, I'm going to hand over to NHS patient and Just Treatment patient leader, Izzy, who is going to speak about why many patients are so worried about their data being shared. So over to you, Izzy.
Hi, everyone. Thanks so much for joining us. And so I have cystic fibrosis, which is a life-threatening chronic condition that causes the passageways in my lungs and my digestive system to become blocked with thick, sticky mucus, and over time it will lead to fatal lung damage. So it basically means I rely on around 4 hours of medication daily and constant hospital appointments and admissions. The unpredictable nature of my illness also means that I could be hit with agonizing pancreatitis pain, left unable to move, or I could wake up with severe chest pain. So I and me, like many others, rely on the NHS to stay alive. But throughout that whole experience of me being unwell and managing my CF without having open conversations, nuanced discussions and face-to-face interactions with doctors and nurses, my health would be in a far worse position. My chronic pancreatitis wouldn't have been diagnosed. I wouldn't be accessing treatment for it. And without the sensitive discussions I've had with my doctors, I've been dealing with pancreatitis since I was 7, and I've spoken to over 6 specialists so far just to get to where I am now. So as we know, last month, Open Democracy revealed that the NHS had ordered English hospitals to share confidential patient information with Palantir. Obviously, I understand the importance of sharing some aspects of health data, especially if it can go towards better development, research, and greater patient care. but not if it comes at the expense of patient relationships and interactions. I have extremely vulnerable conversations with my healthcare team on a weekly basis, whether that's talking about my digestive and stomach issues, or even more sensitive topics like my life expectancy, my fertility, and potential transplants I might need. Some of the conversations I have with my CF consultants and nurses are so delicate, I wouldn't even feel comfortable sharing that information with my own family. And it's fair to say that if I couldn't have these conversations in private with my CF team, I wouldn't have them at all. Central government should not be able to access delicate health records, never mind corporations that will try to use our data to turn a profit in ways that we know nothing about. The assurances we've had on how these concerns will be addressed are next to useless. Schemes like the Federated Data Platform undermine patient trust in the NHS. It will also undermine the care that they receive, and ultimately patients will become apprehensive and scared to seek medical help. When dealing with sensitive topics, people are unlikely to take the risk if they think their information could be shared, and rightly so. But this will likely lead to people suffering in silence, which on a wide scale will have catastrophic impacts on people's lives and on our already overstretched NHS. So let's make it clear that our health data should be used to help the NHS and its patients, and not towards the profits of big corporations. Corporate monopoly power and profiteering have no place in a public health service, especially if they come at the cost of patients' trust in their doctors and the NHS as a whole.
Fantastic. Thank you so much, Izzy, for coming tonight and for sharing your story as well. It's really powerful, and yeah, just shows how important this issue is to get right and what's at risk if the government gets it wrong. So yeah, thank you so much to our brilliant speakers so far. We now have hopefully around 15 minutes for some questions and answers. So thanks to everyone who's shared a question so far. We will do our best to respond to as many of them as possible tonight, but we'll be sure to note all of them down in case we don't get to every single one. So feel free to keep posting them in the chat as we go, and we'll try and keep up. But first up, oh wow, there's a lot of questions. First up, I'm going to go to Corey. So a question that was raised earlier. So some people, Mark said that I've spoken about the FDP and its procurement in other meetings. There is a lot of concern about no detailed specification. Some people have come back that actually the details are very specific, but not public as it's part of the procurement process. So the two questions as part of this are, A, is it legal / morally right to not let the public know what the government is buying? And B, does anyone have access to these supposedly detailed specifics?
So let me give a short answer and then a longer answer. The answer is 1, in our view, no. And 2, even those who seem to have access are scratching their head when they look at the procurement documents, because I've spoken to other people who are in this, and they're like, as far as we can tell, what the government has said is we're not entirely sure what we want to do. We just know that we want Palantir to build it. It doesn't quite say that, but it has a lot of languages in the tender using kind of private languages very similar to Palantir's, right? Like kind of purpose-based access controls and other stuff that is basically kind of Palantir trademark. But I want to focus on the first question that Mark asked, which is it okay to make such, and they say this is their own words, transformative change to the way that the health data of this country is managed without going out to people and consulting them or seeking their consent? They say they don't have to do it because they have other legal bases for centralizing access to your data, and because some of it is, quote, pseudonymized. But for the GDPR nerds on the call, which may be about 2 of you, pseudonymous data is not anonymous data. You can be re-identified from it, and it is therefore in the law, as it still is. They're trying to change this, folks. So, you may all have to get your pitchforks out. It is still personal data and is still entitled to those protections. What we say, in short, and this, this may well be what crystallizes into the legal case, not to give away the legal case, but we're gearing up towards this legal action, is that if you're going to make these seismic changes, that actually it's wrong. It's wrong morally, politically, and we think wrong in law, actually, to do that without meaningful consultation or seeking patient's consent. I think the other thing I would say in terms of what should happen is that at the moment, what we've got is a really blunt opt-out tool. You've got this thing called the National Data Opt-out, and it's very much a kind of baby with bathwater system. You're basically, everybody's in for all purposes other than your direct care, or everybody's out for all purposes other than your direct care. And when you hit the button on that, which by the way, I'm sure some people on this call have, because over 3 million people now have, because of the repeated trust messes that this government has made. Some pretty good uses of involving planning that would potentially help the NHS do better, go right out, along with all of the other objectionable things about private access. So one of the things we think should happen is that actually this kind of dissent process, the consent process, should be redesigned to give all of you a little bit more specific control to say, I mean, I'm happy with this kind of stuff, but actually not this kind of stuff. Anyway.
Fantastic. Thanks so much, Corey. There's a lot going on in the chat, and I can see Marcus is also responding to some questions in the chat as well. So please do keep an eye on that for some interesting stuff. I'm going to kind of combine sort of like 2 questions again, if that's okay. So there's some questions that have been asked around basically Palantir being the front runner and how we know that, how we know for sure that they are the front runner. And then there's also been a question that I think Marcus did also respond to in the chat, but that maybe could be expanded around, if it wasn't Palantir, you know, would we still have the exact same concerns, basically? Sort of how much of our focus in terms of what we're worried about is on Palantir versus on the FDP as a whole, or is it equally balanced? And yeah, Corey or Marcus or Diarmuid or anyone who wants to come in, feel free to come in.
I mean, everyone knows it's Palantir, but I wonder like how long we've done. I mean, Marcus, how would you answer that? I mean, the current system, you go, please.
I mean, I would say that I have grave concerns about the use of Palantir because they are a spy tech, military tech company, and that has absolutely no business being involved in healthcare. I mean, I'm not so naive that I think we can live in a world where there's no spy tech and no military tech. I mean, those things are awful, but they maybe have to exist. Like, that's not my area. I don't go into that. I'm a healthcare professional. And what I do expect is that military tech people stay out of my area. So military tech might need to exist, in which case off they go, but they should not be delivering healthcare. So massive concerns about Palantir as the delivery mechanism for this, for a number of reasons that Corey has already outlined. But I spent a lot of my time, when I was talking earlier, highlighting how dangerous it is for the government to have this data, whoever they partner with in terms of technology, because I just have a real strong concern about the potential for abuse of this data. And if you need any evidence of that, you know, NHS Digital had a memorandum of understanding in 2018 with the border force via the Ministry of Justice, and they were actually we don't really know exactly the specifics of what was disclosed, but potentially names and addresses of people who they thought might have been illegal immigrants, in inverted commas, and that would have come from your GP database. So, and that actually did happen, and it was one of the reasons that Kingsley Manning resigned as CEO of NHS Digital in 2019, and he actually wrote interesting, for anyone who wants to read about that, he wrote an interesting letter to the BMJ about the FDP and about the current plans. And he also, there was an interesting article in the Independent that from around 2019 that detailed that entire process. So when I say that the government will abuse any data that it's got access to, there's proof from the form that they have that that's what they will do. So I'm not just a sort of tinfoil hat wearing conspiracy theorist. I think it's entirely valid for us to want to protect this data. So I don't think it's purely about Palantir, but I'm especially concerned because it is Palantir.
Thanks, Marcus. Corey, anything you wanted to add, or should we go on to the next?
I think there are so many questions. I'm going to give people a chance, so let's crack on.
Great. Okay, another one I've seen is around basically like the timelines for this. I wonder if, Corey, you could maybe give a bit of a sense of that. Basically, what does the kind of like roadmap look like? When is the procurement going to close, and then when could we expect this to come into force if it's not sort of like stopped or halted along the way?
Great question. Time to act is now, team. We're in stage 2 of the procurement, and that is going to run until I think the end of September, although these things do have a way of kind of running on, but let's not assume. So look, the government is going on with this procurement. They're kind of, you know, they're very much hoping it will go through and that there won't be a kind of national scale kerfuffle of the scale that there was over the last GP data, where there was such an outcry, as everybody has rightly said, with over 1 million people further opting out in a month because of the failure to secure trust, that they had to pause that system. This system, if anything, has had less work done at the front to kind of deal with governments and patient consent than actually GPDPR did. And yet they appear to be plowing ahead. But I would say, look, as well as the kind of legal action that we are gearing up towards, I hope that all of you on this call have already signed and written to your MP via the actions that we have. And if you haven't, please do so. And not only that, tell your friends, if somebody hasn't dropped that into the chat, please could you drop the link into the chat, because MPs actually do care about the volume of letters that they get from their constituents. And I think that it's not too late to get Parliament and others to kick the tires of this on a pure value for money basis, because there is a need, as we all know, to find some money to resolve some of these pay disputes, for example. So I mean, at some point, if there is enough debate about it, the debate tips over into, well, hang on a minute. I mean, we've decided, we're desperate to try and find some money to go and actually pay our healthcare professionals, and yet we think that we need £500 million on a dashboard. Like, actually, maybe we need to revisit this decision. So there's a chance, I think, it's not totally in the bag yet. Palantir is absolutely front runner. There are people in government who absolutely want to do this, but there is dissent. People phone us up from different aspects of the NHS all of the time saying this is a waste of money. It's not going to work. So we just have to build a critical mass, people.
Yeah, agreed.
Brilliant. Thanks, Corey. A question for you, Marcus. I'm just going to keep firing them out there for the next 5 minutes. Someone has asked, how much contact have those in charge of the contract or government officials had with medical professionals in regards to how this might be implemented? So I guess a question about, to what extent, if at all, have medical professionals been feeding into kind of these decisions in this process?
Absolutely none. So the predecessor to this project, which was called GP Data for Planning and Research, did have lots of engagement with the profession, and we spent quite a lot of time honing the understanding of what they wanted to do and our understanding of how they would do it. And then they've essentially put that program on pause to work on a completely new program, which has none of the oversights. I don't know which clinicians are involved in the planning of this project. There will be somebody inside NHS England who has been tasked with this, but I don't know who they are. And as I'm fairly involved in health IT and GPIT, I should know. It should be a known thing to me who runs this project, but I don't know the clinician who's in charge of it. So this is a runaway project. It is a chaotic entity that it shows signs from the outside of having nobody in the program who actually understands GP data or NHS data in a wider sense, because they keep mixing up different uses of data. So in their blog posts and the various tidbits that we've been thrown over the fence from the NHS England, they've suggested that anything that is in the headlines at the moment could be solved by the Federated Data Platform. So when there were problems over winter with the bed blocking and problems with discharge into social care, they actually even suggested that this Federated Data Platform would somehow enable a smooth flow of data throughout the journey of the patient, so that they could end up in social care bed with all the information that they need wherever that was. And that's an absolute fiction, because the number of systems involved there are myriad, and none of them are connected to the FDP. I think it's important to remember that the FDP does not connect everybody to everybody else at all. The only thing it does is connect everybody to NHS England. So NHS England from their ivory tower would be able to look down and see the landscape of the NHS and where the long waits were in A&E in real time. They might be able to see where the problems were in cancer care. They wouldn't be able to necessarily do anything about those problems, because they fundamentally haven't engaged with any of the people who deliver care to be able to have a lever that improves cancer care. So all they'd be able to do is harass from NHS England. They would be able to put more pressure on the people who are doing badly, which is, something that they still haven't learned doesn't work. So, we understand in a wider societal context that if people have been privileged all their lives, they often achieve they're high achievers in society without any additional work. And people who've been deprived often don't do as well in life, even if they work really hard. And we have the same disparity of outcomes across the NHS in terms of performance. But shouting at deprived people doesn't make them rich. And shouting at NHS providers that are not doing well does not turn them into global exemplars. So that NHS England have not yet developed even rudimentary mechanisms for improving the disparity of care across the UK. But what they want to do with the FDP is dashboard it all, which will of course lead to more pressure to improve areas that are bad because they look bad. And that no one has actually bothered to think on into the problem far enough to be able to say, well, what will we do next after we have a dashboard? So the entire program is a nonsense, and I happily see it destroyed tomorrow by anybody, any governmental body that felt that it was as ridiculous as it is. It's a waste of money.
Great. Very definitive. Thank you, Marcus.
I'm not going into my words.
Gonna squeeze in a couple more questions super quickly, but just to say to the people in the chat, do not worry, the final section of this call is all about the campaign and the actions. So we're going to be sharing lots of links about what you can do just as soon as we finish the Q&A. So hold tight on that front. Corey, going to come to you with sort of, again, two questions just mushed into one, if that's okay. We've had a question about clarifying, is this just about NHS England, basically, and whether there's any potential things to be worried about in terms of whether it could end up going beyond that and in relation to like devolved nations. And then also just, I know you briefly touched on the opt-out thing earlier, but just in terms of someone asked a question around if people had previously opted out of like previous iterations, whether that means anything now, whether we know the answer to those questions. So yeah, devolved nations and opt-out, if you could speak for 1 minute on those, that would be great.
One of those is easy and one of those is hard. Devolved nations are not included. So if you are in Scotland, you can kick your feet up or, hang up if you don't care about us in England. And then, the status of your opt-out in this, I think, is actually a little bit less straightforward because they say that the opt-out is going to be applied to some things. But at the same time, there is a suggestion, I think, that kind of consent and dissent are not necessary for certain applications. And I realize that those two things sit together in a quite confusing and worrisome way. Let me ask Marcus if he feels any clearer about how consent or dissent are going to be opted or are going to function. I mean, what we feel worried about is that we think that the national data opt-out isn't really fit for purpose for this, basically, because we think that everything is thrown out all at the same time, including stuff that people might not want to dissent to. But anyway, Marcus, have I misunderstood?
Well, again, this is because we don't have any details of how they plan to manage this. We don't have any details about how they plan to manage consent, opt-out, and dissent, etc. So we have the existing controls that are in things like the national data opt-out, and there is something called a type 1 opt-out, which is something you can apply that prevents your GP record leaving the GP system. But there's been no proper discussion about how the complex issues of consent as we move forward into a really quite data-oriented world, how will that be managed? Because I can imagine that an individual patient might have a number of different choices to make, and many of which will be confusing as well. So it's not, we could give all those questions to a patient, but we might not be able to make sense of their answers or have confidence they've understood the consent. And of course, consent without understanding is not valid consent. So, for example, when a patient opts in to a research project, are they opting into a specific one or to all research? Now, I think that in the mind of most patients are two very different questions. Patients might want to opt into a specific research project, which at the moment they do. Most research is consented. And if you're in a research project, you would know about it. However, there are some research that is done that has been done without consent on the basis that it's on the best interests of the patients in the whole NHS, but it doesn't go into personal data. It doesn't go into that level of detail. So there's a whole load of complexity around this. The very first stage of managing that complexity is to start having a discussion with the profession and the patients about what they want. And then NHS England has decided that mother knows best.
Thanks, Marcus. That's super helpful. And just before we move on to the action section, there's been a couple of questions just about the role of ICSs in this whole picture, basically, and whether that's a potential pressure point on a more sort of like regional level around this matter. Just wonder, Marcus, if you could give like a 30-second insight into the role of ICSs within this, basically, and within the campaign, and for the potential to challenge it.
Okay, so I guess the 30-second top line thing is that ICSs are a relatively new body, and I don't think anybody really fully understands how they will work, because they've only been around in the last year or two, really. That's not long enough for us to have a proper understanding of how they will work. And secondly, ICSs are particularly dependent on GP data if they're to do anything useful, such as if you decide as an ICS that you want to invite all patients that have a particular condition to an ICS specialist clinic, and you want to send out an invitation. In order to do that, you would need detailed access to their record. You'd need to know from their GP record which patients have that condition. Now, at the moment, the Federated Data Platform doesn't plan to have GP data in it at this stage. It will have lots of other very disclosive data in it, but it doesn't plan to have the GP data in it. Now, I think that in future they will put it in, so I'm very concerned about the FDP from that point of view. But as it stands, the FDP is of no use whatsoever to the ICSs. It's almost, you couldn't write it.
Fantastic. Well, not fantastic, but fantastic to have you guys here answering those questions. Thanks so much to Corey and Marcus. Okay, we're running a little bit behind, but I have confidence that Diarmuid will be able to run through the last bit very swiftly. So yeah, that's all the questions we've got time for. We are going to save the chat. Sorry if we didn't get to your questions, there was a lot, but we're going to save the chat, and maybe we'll speak to Foxglove about trying to do some sort of blog where we could maybe try and answer some of the ones that we didn't get to. So anyway, for the final section, I'm just going to hand over to Just Treatment Director Diarmuid, who is going to talk about our coalition's campaigning efforts so far, what comes next, and crucially how you can get involved, including from right now. Diarmuid.
Thanks, Hope, and thanks, Corey and Marcus and Izzy and everybody for joining. Yeah, we promised we wouldn't go beyond 9 o'clock, so I'm going to do my level best to squeeze what should have been 10 minutes into about 3. So, cut to the chase. We're all deeply concerned. There's a whole, close to 200 people on this call, worried about what's happening. We want to figure out what it is that we can do collectively to push back on this and to get the proper kind of consent and oversight and strategy from government around how our NHS data is handled. Now, we wrote to the government asking for answers to critical questions about their plans twice last year. We got no response. So back in March, our coalition, which included Foxglove and a few others, sent a legal letter to the government seeking information about the data platform. Now, we have not yet got satisfactory answers to how they're going to ensure they protect patient trust and consent. And if we do not get those satisfactory answers, and we really don't think we're likely to, we do intend to proceed to taking the government to court over these plans. But alongside that legal effort, just like the last time we had the fight over the GP data grab a couple of years ago, which Corey spoke about, we also need to build a mass nationwide campaign to urgently raise awareness and to force politicians to take notice of this and to speak out against what is happening. So we've already launched, as has been mentioned before, a letter writing action for members of the public and supporters to send to their MPs. Hopefully, we're going to be sharing the link to do that. If you haven't taken that action already, over 3,000 supporters of Foxglove and Just Treatment have taken that action already. If you've not done it, as Corey said, please do it. Please tell your mum to do it. Tell your cousins and your dog, everybody, take that action. It's super important to put pressure on MPs. Now, we also want to ensure that there's a high level of understanding and knowledge about this. Foxglove are doing amazing work in developing a new briefing on the FDP for MPs very soon. Watch out for your email inboxes. We'll be getting in touch to share that with everybody that's taken the letter writing action, so you can follow up with your MPs to say, yeah, thanks for that brief reply you give to my email. Here's a briefing to kind of set out in detail why we're concerned. Now, alongside that, and I think I would not be alone in saying that some of the contribution that Izzy made tonight was some of the most powerful things that we've heard on this call, and what we really understand as Just Treatment is the power of personal testimony from NHS patients about how these plans may impact them and their trust in accessing healthcare. As I said, there are dozens and dozens and dozens of people on this call tonight. That's a real sign of concern. And what we want to do is to collect stories of why people are concerned, why you're worried, so that we can use those to amplify the voice of patients in this debate and start to translate what can be quite a technical, complicated subject into something that people can see themselves in and understand how it impacts their lives and their healthcare. So if you rely on the NHS and you've got a perspective to share on this, please get in touch. Hopefully we're having another link being shared in the chat now that allows you to really, really simple, just tell us why this matters to you and why you're worried and how you fear it might impact you. Finally, make sure you're all signed up to Foxglove and Just Treatment's mailing lists. That's where we're going to share all the news, actions and events related to this campaign. As Corey said, the plan is gearing up towards a legal case, and we want to make sure that everybody that's on this call and everybody else that's worried about it is kept up to date on that. Don't worry if you haven't been able to save the links. We're going to send out an email next week with a link to the recording of this call and all the relevant information. We'll also be getting in touch with you about further actions and campaign plans that we're working on right now in the days and weeks to come. Thanks so much for all of you for joining. I'll hand back over to Hope.
Great, thanks, Diarmuid. There's not much more to say. That brings us to the end of the call. Thanks for running through those actions. As Diarmuid said, we'll be sending all of them out via email. Thanks so much to all of our brilliant speakers for your contributions. Thanks so much to all of you for joining us tonight, for all your great questions and your enthusiasm for getting involved in this critical campaign. We have forced the government to back down on dodgy data grab plans before. We know we can do it again if all of us work together. So keep an eye out in your email inboxes for next steps and updates. We'll see you all soon and have a great evening. Take care, everyone. Bye.